Welcome, everyone. Thank you so much for joining us today at the Center for Healthcare Strategies on this important topic of maternity care workforce expansion, creating new opportunities for doulas. This webinar is made possible by the California Healthcare Foundation. Before we get started, we just have a few housekeeping items to get through. Please note that all participants are muted and only speaker cameras and mics will be on during this session. The chat feature is disabled for today. We will have a moderated Q&A in the last 15 minutes of the session today. We welcome you to submit your questions throughout the webinar. My CHCS colleagues, Anna Benio and Carla Silverman, will be monitoring the question box and we'll get to as many questions as possible at the end. Our agenda for today includes introductions and a background on the need for maternity care workforce expansion, the Medicaid doula coverage landscape and insights from California, and a spotlight on New Jersey's lessons on expanding the doula workforce. We will end with the moderated Q&A. Next slide, please. This is our team and our presenters for today. I will introduce our panelists shortly, but first we'll hand it off to Amelia Cobb, Senior Program Officer at the California Healthcare Foundation, to say a few words about this project.
Hello, everyone. I would like to thank the CHCS team and panelists for joining and hosting this webinar today. CHCS is working to support birth equity, especially Black birthing people, and supporting the doula implementation in California. This work is a very important part of that. We feel like this webinar is also an opportunity for you to learn more and have a cheat sheet on what's happening in the maternity care workforce and expansion. Thank you again to the CHCS team and panelists. I'll give it back to you, Preeti.
Thank you, Amelia. We are very excited to be joined by three amazing panelists today, Amy Chen, Linda Jones, and Dr. Xinyi Lin. Amy is a senior attorney in the National Health Law Program's Los Angeles office, where she conducts research, advocacy, and education on reproductive and sexual health access and services. Her areas of expertise include pregnancy coverage, maternal health, and Medicaid coverage for doula care. Prior to joining the National Health Law Program, Amy worked as a legal aid attorney in Oakland, California for 8 years. Amy has 3 children and had doulas for all 3 of her births. One of her children was born prematurely and spent his first weeks of life in the NICU. Linda Jones. Linda is a birth and postpartum doula, photographer, mother of 2, grandmother of 4, and great-grandmother of 4 in Oakland, California. She has been a part of the natural birth advocacy and reproductive justice community in the Bay Area for over 3 decades. Linda is one of the founders of the Black Women Birthing Justice and is co-author of Battling Over Birth, Black Women and the Maternal Health Care Crisis in California. Linda's recent work has been centered around training and mentoring women of color to be doulas for low-income women of color. She's also a member of the UCSF Preterm Birth Initiative Community Advisory Board and Director of Community Collaboration and board member for Mothers Postpartum Justice. For Linda, helping families bring babies into the world and get their family started in the best way possible has helped her heal her own traumatic birth experiences. Xinyi Lin works in the Policy Office of New Jersey State Medicaid Agency, New Jersey Department of Human Services, the Division of Medical Assistance and Health Services, on maternal health policy, including the recent implementation of New Jersey's community doula benefit in 2021. Xinyi had birth doula support for all 3 of her births in New Jersey. She comes to policy work by way of a career as a geneticist, bringing her perspective as a scientist to support evidence-informed, evidence-based policymaking. Next slide, please. Before we pass it on to Amy Chen as the first speaker for today, we want to emphasize the growing evidence that shows health disparities which disproportionately affect Black, Brown, and Indigenous mothers and pregnant and birthing people. A new CDC report from the last month shared 2020 maternal mortality rates that documents a 14% increase in the number of maternal deaths between 2019 and 2020. There are stark racial disparities in the data. 1/3 of pregnant people and new mothers who died in 2020 were Black. though Black Americans only make up just over 13% of the US population. This is a rate that is nearly 3 times higher than that of white women. Next slide, please. Additionally, the US is experiencing a shortage of trained maternal health care providers and support staff, especially in rural and urban maternity care deserts, and this has a direct impact on the health of women and families. States and health systems can address this maternal health workforce shortage and increase access to care and improve outcomes through a variety of approaches, including by expanding the midwifery workforce, the doula workforce, utilizing community health workers in maternity care, and growing and sustaining the OBGYN workforce in rural and urban maternity care deserts. As the focus of today's webinar, one approach to improving maternal health outcomes is increasing access to innovative and evidence-based strategies to address Black, BIPOC, maternal mortality and morbidity in women and birthing people served by Medicaid. One promising approach is to increase the supply of and access to doulas, community-based trained professionals who provide emotional and physical support to women and birthing people during and after pregnancy. Additionally, strengthening and increasing racial and ethnic representation among the current and future doula workforce can lead to more equitable birth and maternal health outcomes. There are key opportunities and challenges in designing the doula benefit in Medicaid and expanding that doula workforce. Today, our panelists will share opportunities and lessons learned from across states. And with that, I'd like to hand it off to our first panelist, Amy Chen from National Health Law Program. As a reminder, participants, we welcome you to submit your questions into the question box throughout the duration of the presentation.
Great. Thanks, Brittany, and thanks for having me. I'm really excited about the conversation that we're going to have today. Next slide, please. So just really quickly, I wanted to mention my name is Amy Chen. I'm a senior staff attorney with the National Health Law Program, or NHELP for short. We're a national nonprofit law firm that works to protect health rights for all, especially low-income and underserved individuals and families. Next slide, please. At NHELP, I'm part of our reproductive and sexual health team, and my focus has traditionally been on pregnancy coverage and maternal health. But since 2018, I've also been leading NHELP's work around Medicaid coverage for doula care. So our Doula Medicaid project, launched in May 2019, really seeks to improve health outcomes for Medicaid enrollees by trying to ensure that all pregnant and postpartum individuals enrolled in Medicaid who want access to a doula will have one. So just really quickly, why Medicaid coverage for doula care? So we know that one piece of the solution that has sort of emerged to help address racial disparities in healthcare, and in particular around maternal mortality and morbidity, is to expand access to full spectrum doula care. This is because doulas can really provide support for pregnant and postpartum people through information, education, as well as physical, social, and emotional support. Individuals who have received doula care have been found to have improved health outcomes for both themselves and their infants, including higher breastfeeding initiation rates, fewer low birth weight babies, and lower rates of cesarean births. While we acknowledge that doulas cannot eliminate individual, institutional, and structural racism in the medical system, doulas can help to improve the maternal health experience and address health disparities by reducing the impacts of racism and racial bias on pregnant and postpartum people of color. Now, most doulas working today are paid by their clients out of pocket. The cost for their services ranges from $1,000 to $2,500 or more. In the introduction, it mentioned that I've had doulas at all 3 of my births, and each of those births cost me between $1,500 to $2,000 for the cost of that doula. So really the high cost of doulas, coupled with largely the lack of coverage in most public and private health plans, means that many people who, especially those who are low income, are just not able to access doula care. At the same time, we know that doulas can really have a profound impact on both maternal and infant health. So the expansion of full spectrum doula care to all pregnant and postpartum Medicaid enrollees can really have a huge impact, given that half of all births in most states are funded by Medicaid. I do want to mention that at the Doula Medicaid project, for the most part, we're lawyers, we're researchers, policy advocates. None of us are doulas. As such, we really seek to do our policy and advocacy work with the Doula Medicaid project in partnership with and with the guidance of community doula groups, doula collectives, and individual doulas, especially Black doulas and Black-led doula groups, as well as doulas and doula groups serving low-income clients. I want to mention that the image that I have on my slide there on the right is we had commissioned from illustrator M.J. Smith, and on the bottom it just reads, all pregnant and postpartum people deserve access to full spectrum doula care. And just to back it up, full spectrum doula care, it just means doula care, not just for kind of prenatal, postpartum, labor and delivery, but also for stillbirth, abortion care, and miscarriage. So really the full spectrum. Next slide, please. And then the next slide. So I'm just going to talk really briefly about some of the national doula efforts that we've been tracking as part of the Doula Medicaid project. We started tracking sort of national efforts around Medicaid coverage for doula care in 2019. There was definitely a clear increase of bills in 2020, 2021, and then there's quite a few bills that have also been introduced this year. In 2020, there were about 16 states that introduced bills. It was, I think, the most bills that had been introduced up until that point. Unfortunately, many of those bills died in committee after the pandemic hit, because many of those states kind of moved from the regular legislative session to emergency COVID sessions. So most of those bills died in committee. In 2021, there were close to 24 states that introduced bills relating to Medicaid coverage for doula care. So there was a pretty significant increase. And many of, I will say many of those bills passed. And so there are several states in the process now of implementation, including California, where I am. And then later we're going to hear from Dr. Shin-Yi Lin, who's going to speak a little bit about what's happening in New Jersey as well. In 2022, this year, thus far, there's currently 4 states that are actively providing coverage and reimbursing. As I mentioned, there's about a dozen states, including the District of Columbia, that are currently implementing coverage, which means they're rolling out their programs for Medicaid coverage for doula care. And there's another dozen states that have taken some kind of adjacent action. So for example, maybe legislation that will ultimately go towards implementation of Medicaid coverage for doula care, but right now just like convening of, say, doula advisory boards or maybe stakeholder work groups in some cases, some bills around doula certification. Next slide, please. Now, in tracking the state legislations and also in our conversations with doulas and policy advocates in many of these states with proposed and now passed legislation, there's just a couple of states that I want to just particularly highlight. Minnesota and Oregon are definitely worth taking a closer look at. Both states have had Medicaid coverage for doula care for quite some time, both of them for several years. There have been some challenges with implementation in both states, though, that I do think have a bearing on just our conversations and considerations about workforce. So as there was a recent series of articles in the Washington Post, which maybe I can share out to the organizers and maybe share out to participants after the slide. But basically, there was a recent series of articles in the Washington Post that discussed kind of Medicaid coverage for doula care and what it looks like in both of those states. In both states, there have been a lot of challenges, in particular around reimbursement rate. In Minnesota, the initial reimbursement rate was $411 for prenatal, postpartum, and continuous support. This is far below the market rate that most doulas are currently receiving in the state for clients that are paying out of pocket. In 2019, legislators increased the reimbursement rate to $770, which is still not market rate, still not sufficient, but certainly better than $411. In part because of the low reimbursement rate, the uptake, so in other words, the number of people that have actually received Medicaid coverage for doula care is quite low. So between 2014 to 2020, it's estimated the doulas provided support for Medicaid enrollees at roughly 850 births, a number that is obviously very low for a state where about 26,000 people each year give birth while enrolled in Medicaid. Meanwhile, in Oregon, the original reimbursement rate for 2 prenatal visits, 2 postpartum visits, and continuous support during labor and delivery was $75. Like literally, I'm not missing a zero, literally $75. After many years of advocacy, the figure was later raised to $350 for that reimbursement rate, but it's still far, far, far below market rate. And again, in Oregon, in part because of the reimbursement challenges, the workforce just wasn't there. There were not a sufficient number of doulas who were able to take those services. Doulas had challenges even getting paid, those who did choose to take that $350 reimbursement rate. And so again, in Oregon as well, the uptake has been very low. In contrast, I wanted to just briefly highlight Rhode Island. In 2021, Rhode Island passed a bill to require doula care in both Medicaid and private insurance. Super interesting. It's the first state that has done that for private insurance as well. The proposed Medicaid reimbursement rate will be up to $1,500, $1,500 for 3 prenatal visits, 3 postpartum visits at $100 each, and then labor and delivery services at $900. The benefit is scheduled to begin on July 1st of this year. So let's see. And I know, I think when we talk with Linda later, we're going to talk a little bit more about sort of reimbursement rate and why sustainable reimbursement rate is so important, particularly when it comes to engaging and maintaining the workforce. Next slide, please. So I want to just distill sort of 3 overarching recommendations for advocates, doulas, and other stakeholders who are really looking to do this work in their own state. So first, I really encourage states to try to get it right from the get-go so that they don't have to do a lot of cleanup on the back end. As I mentioned, both Minnesota and Oregon, they both passed Medicaid coverage for doula care several years ago, but over the years, they've had to pass successive legislation to fix or improve upon their original legislation, including, as I mentioned, in both states, increasing the reimbursement rate. Also, they've made changes to billing structure and, a lot of other changes. So states really have an incentive to be thoughtful and try to craft an equitable, sustainable, and inclusive program for Medicaid coverage from doula care from the start, so they're not having to do all of this cleanup years and years after the benefit actually has begun. Second, I want to also really encourage the legislators, doulas, policy advocates, and community members who will be implementing Medicaid coverage for doula care to make sure that at every step in the process, community-based doula groups who are already serving those low-income clients, those low-income Medicaid enrollees, and who are already serving pregnant and postpartum people who are Black, Indigenous, and people of color are really front and center in crafting that policy language and determining how it's going to be implemented. As I mentioned earlier, I'm not a doula. As such, with the Doula Medicaid Project, we've always sought to do our work in partnership with and really with the guidance of community-based doula groups, doula collectives, and individual doulas, especially Black doulas and Black-led doula groups. And then third, as firm as my faith really is from my own personal experience in the power of doulas to positively impact the lives of their clients, I also know that in the end, we can't put it all on their backs, right? So for sure, doulas can definitely help mitigate the impacts of racism on their clients of color by advocating for them in the face of individual, institutional, and structural racism in the healthcare system. But in the end, that individual, institutional, and structural racism, it's still going to be there. It's still going to be harming other people. So doulas may be necessary, but they alone are not sufficient. Really the solution to the underlying racism that plagues America's maternal healthcare system, it can't be solved simply by throwing doulas at the problem. So, that is one of the tools, but there's other things that also need to be done. So, as I do this work, and I encourage, others who are doing this advocacy work as well, to just remember this, and remembering it, continue to work in other ways to seek out and eradicate racism in all its forms. Next slide, please. And then next slide. So I just want to share really briefly a couple of additional resources that you can go to for more information about some of the work that we've done. Just earlier this month, we kind of published our California Doula Pilots Lessons Learned project. This was actually a project funded by CHCF. Thank you, Amelia. And Linda Jones, who we're going to speak with, was an integral part of this project. This was basically looking at 10 doula pilot programs in California that all had a primary focus on addressing racial health disparities, and in particular on providing free doula services to either Black pregnant and birthing people or Medicaid enrollees. The project consists of a set of publications and resources that were created from our interviews with people who are doulas and sort of program administrators who are involved in 10 of these doula pilots. And the image that you see on the screen was a visual recording by a visual scribe named Ashanti Gardner that we worked with. Next slide, please. And then also as part of this project, we held a panel discussion with representatives from 6 of the interviewed doula pilot programs. Linda was one of the panelists, and you can find all of that information and the publications on the link that I have there on the bottom of the slide. Next slide, please. And then lastly, I just wanted to mention another publication that we have, which was report that we put out in May 2020 called Building a Successful Program for Medi-Cal Coverage for Doula Care, Findings from a Survey of Doulas in California. This report is really the distillation of a survey that we did of doulas across California, as well as a series of focus groups. And I would say, even though the findings were specific to, or rather, even though the folks we talked to were specific to California, I will say that the recommendations and other findings that we have that are shared in this report really resonate and are very much consistent with the conversations that I've had with doulas across the country. And then you can find that at the link there. So that's it. Final slide is just my contact information. Please feel free to let me know if you have any questions, or for sure, let me know if there's any support that I or NHELP or the Doula Medicaid Project can provide with your own advocacy in your state.
Great. Thank you so much, Amy, on that informative presentation on the national landscape of doula Medicaid coverage and what's going on in California. A lot of awesome work there. I am pleased to welcome Linda Jones for a conversation with Amy on additional considerations for designing the doula benefit from a doula perspective. Welcome, Linda.
All right, great. Hi, Linda. And again, as I mentioned, Linda has been integral. She's one of the I would say community-based doula leaders that is helping to lead the advocacy efforts with implementation of the doula Medicaid program here in California. So I guess I just wanted to start, Linda, can you just give us a little bit of background information about how implementation has been going in the state so far?
Sure, and thank you, Pretty, for having me. I appreciate the opportunity to speak with you all. Yes, so I believe it's since last September that we started the stakeholder group dealing with the Department here of Health here in California. And to say it's been shaky is an understatement, but I think we're getting there. It started out very, very rocky because it was, I give them points for at least attempting to talk to us, to have us in the picture from the beginning of what they were doing. But there were so many roadblocks that flared up at that first meeting that it really got off to a bad start. We worked through that a little bit. The next couple of meetings were also a little sticky because, and the stickiest part was the 450, which is what they had in the budget to be paid. And you've already talked about how that's not doable. So we could never kind of get past that part because they would never be transparent enough with us or tell us whether that really is the number or how we could change it to make it a better number. And then there was a question about supervision, that because it was in that preventative box under Medicaid that we were supposed to be supervised, and that didn't go over well either, because doulas are not supervised, and the way we work is not through supervision. So we did get past that one, and I think we got that off the table, and it's become a recommendation now, which we can live with. And now we have hired, we didn't, but they hired a facilitator to come and be with us in the meetings, which has made it go a little bit smoother, because it's someone that kind of holds them accountable to give us feedback and to get our questions answered. We have another meeting with them, a large meeting this afternoon. So we'll see how that goes, where they're going to talk about the SPA, the SPA. So yeah, I think it's really important to have the people who are doing this work at the table, because we've seen in other states that it doesn't work if you don't have us there. And we've put in many hours of telling them what we think would be a good program, all for free, because we're not getting paid for it. And if they take what we were saying and maybe with a few more tweaks, I think it could be a good program. But if they roll this out in any form with that low of a reimbursement, it's not going to work. So.
Thanks, Linda. Can you talk a little bit more about, I know you mentioned the 450, which is what we were told was the originally planned reimbursement rate, which, as I mentioned earlier, now after years, Oregon is at 350. but it's still not close to market rate, and that's been one of the big challenges in that state. Can you talk a little bit more about just sort of how rates and kind of equitable and sustainable reimbursement rates, or rather, sorry, can you talk about sort of how rates and reimbursement can really reflect the nature of doula work, and how equitable and sustainable reimbursement rates can help to support a living or thriving wage for doulas who do this work?
Yes, that's a big part of what we're talking about here, because people that become doulas are a special kind of person. We really want to take care of people. We want to nurture people. We want to help people, and we want to do this as a living. And I decided to do this. It was like I found what I wanted to do when I grew up, when I was 30 years ago, and I was like, this is what I want to do for the rest of my life until I can't do it anymore. And I want to be able to make a living doing it. I don't want to have to still work at a 9 to 5 and do this on the weekend, because that's not how it works. Babies come when babies come. I'm on call at the moment. We have to be paid well to do this work. And, when I started out doing this work, I got paid $250. And I thought it was great, but that was a long time ago, a very long time ago. And now we're living in California, where gas is between $5 and $7 a gallon, and we have to drive to these places to see our clients, and a lot. And groceries are expensive, and housing is impossible. So if you want people, like you said, they want doulas to be the answer. We're not the answer. We're just part of the answer, because we're not the ones that are killing anybody. We're trying to keep them alive. So either we need to address the people who are killing them, or pay the people who are trying to help them stay alive better. So if we're not paying people, and the other thing is, Medicaid tries to compare, what they pay doctors, let's say, for taking a Medicaid patient. Well, doctors can see, 5 to 20 people in a day. We can only do 1 or 2 births a month. So we can't string together 10 doula jobs in 1 month, because it's impossible to do that, because babies don't come on that day that somebody said they would. They come when they feel like it. And so, to take care of yourself in doing this work, which is hard work. It's hard mentally, physically, and psychologically. And to do this work, you have to have some downtime in between. So the most you could do is maybe, I used to do 2 to 4 births a month, and that was, 4 was really pushing it. 2 is optimal, so that you can take care of them and take care of yourself. So if you're paying somebody $450 to do all that we do as community doulas, and I'm not particularly a community doula myself, to be transparent. I've done most of the work of my life working with white women who could afford to pay me, but now I'm transitioning into helping Black women. I'll do a Black birth for free, but we can't keep doing that. We really can't. So to ask somebody to do 2 births a month and get paid $900, and not only get paid $900, but not know when that $900 is going to show up, is ridiculous. Because Medicaid is notorious for not paying on time. You have to go through the whole government routine to get a paycheck. So you cannot, get paid for something and then not get to see the payment for 3 to 4 months down the line. That just isn't going to work. So they have to figure out how to pay us, a living wage, and to be able to pay us in a timely manner to do that, or else this just won't work.
Thanks, Linda. I think we only have another couple minutes left for this portion, but I think in the time that we have remaining, I wanted to kind of ask you a little bit about something that you mentioned. What are some things, you spoke a little bit about sort of having, doulas be sort of culturally aligned with their providers. You mentioned that you used to serve mostly white women and now you're serving Black women. Can you talk a little bit about why that's important, that sort of cultural congruency?
I think it's very, very important for a Black person to have a Black doula. For many reasons. Most of all, because it's the person that looks like them, and they feel more trust that way. This is America, let's face it, and it's racist. And the most well-meaning young white girl is not going to be able to, she'll be able to help, but it won't be the same as if I'm there, because I understand the culture. I always tell people that, it's like, I'm not afraid to be with this Black family. Some young white girl might be afraid to be working with this family or go to their homes or whatever. But, if Chloe wants crazy Uncle Joe at her birth for whatever reason, I'm not afraid of him because there's a crazy Uncle Joe in all of our families and we know how to tell Uncle Joe to go sit down and be quiet, but that would scare some people because he's loud and, so we have to have people who understand us, who understand what racism looks like, because sometimes people miss what racism is. They may just think someone's being rude, but they're not. They're being rude, but they're also being racist. And you have to have someone who has gone through those things to know and recognize them and be able to protect you from it while you're trying to birth your baby.
Thank you, Linda.
Great, thank you so much, Amy and Linda, on the priorities of doulas integrating into the Medicaid system. Those are really thoughtful responses and we appreciate that. I am happy to welcome our next panelist, Xin-Yi Lin, to talk about New Jersey's lessons on expanding the doula workforce.
Thank you for the opportunity for us to share a little bit about the history and the lessons around building a community doula benefit to support our Medicaid birthing population in New Jersey. So my presentation is going to touch upon a couple specific aspects of the work we've been doing, work that started about a year or so before COVID and continues on to today. There are some parallels with things that other speakers have already said and some unique aspects about how our community doula benefit has rolled out in New Jersey. And I hope that some of the background framing will help clarify sort of why did New Jersey make some of the decisions it did and just understanding the rationale, because I think that that is really important. I'm going to try and cover 6 takeaways during my presentation and hopefully just highlight some themes for people. So on the next slide, I want to talk a little bit about how our doula benefit was built upon within the context of a statewide initiative, spearheaded by our governor's wife, First Lady Tammy Murphy. It's called Nurture New Jersey, and there was a strategic plan that was published last year. And this is important to understand that we're really thinking about the community doula benefit in the context of a larger need to address maternal health in our state. Relevant to the introduction that was given, yes, our state not only has some maternal health statistics that we would like to improve, but specifically we have particularly poor statistics around racial health disparities. And so a lot of the maternal health work that we're doing is not just to generally improve maternal health, but to specifically reduce the racial disparities that we see. And so that is one takeaway I want you to take, is that our state is really focused on that need to reduce racial health disparities. I think a second takeaway related to something that Amy said about doulas can't do it alone is that we are trying to do it in the context of system-wide change. The box on the right is only focused on the initiative specific to New Jersey Medicaid. The strategic plan deals with a lot more broader things with other state partners. But as you can see, hopefully, is that the community doula benefit is in the context of other maternal health related reforms that we're doing and benefits that we're launching in Medicaid. And in particular, you will see that the doula benefit has really benefited from a close relationship between my department, which is the Department of Human Services, and our sister department, Department of Health. And I'll get to that in about 2 slides. So in our next slide, I wanted to talk about some highlights of what New Jersey's benefit is. And then I'll get into sort of the why and how we got to this. So number one is that our benefit was really tailored or meant to be tailored for what we're calling community-based doulas. So these are doulas that come from the community that receive specific training on understanding community-based social supports that are provided not only by the Department of Human Services, but by other departments across the state. And again, reflect the clients that they are serving. And that may be different for your state if you're looking to roll out a benefit because, you know, you might want to focus on a different segment of the doula workforce. That's sort of something that each state needs to sort of have a conversation about. Our benefit is available throughout the perinatal period. And in particular, even though we cover visits that can span the entire period, we also are agnostic if for some reason a member does not learn about doula care until maybe they're in the hospital or they've already given birth. You can certainly pick up community doula care in the postpartum period. And we tried to also be expansive in terms of, you know, where those visits could occur. They could be in the home, which is often where people are thinking, or maybe in the hospital for labor support. But they can also, you can meet in the community if the client, for whatever reason, does not want to meet in the home. Or the doula can also accompany a client to a clinical visit, like to with their obstetrician or maybe with a pediatrician in the postpartum period. Another unique aspect is that we provided a value-based incentive that was built into the benefit for improved coordination of care. So if the client goes to see their obstetrical clinical postpartum visit, then the doula gets an additional $100. And the other thing we did was have sort of an enhanced visit option when the client is younger. So for 19 years or younger, instead of the standard sort of 8 visits at any time during the perinatal period, you get up to 12 visits. And then the last thing, which is really about how these providers are engaging with both with our managed care organizations and within our fee-for-service program, is that the doulas have a choice to practice independently, or they can also join doula-only organizations. So these are organizations that would be like doula-led and only provide doula services. And they can also participate with clinical groups, like if they want to join a midwife group or a doctor group. So I want to go back to that partnership with our Department of Health in the next slide. Because I think it's important to talk a little bit about the workforce support New Jersey was doing before we launched our Medicaid benefit. This was largely spearheaded by our Department of Health, but also a number of key nonprofits in the state that were really investing in maternal health work in the state. And what that meant is prior to Medicaid benefit launch, there were already established 4 community-based doula training sites in the state. These pilot sites provided training free to the trainees in a training program that was not just a community-based doula model, but also incorporated regional specific. So not just New Jersey specific, but regional specific training. And then these pilot sites, in addition to sort of training a small workforce in their that came from the community in the area, they also, once they were trained, paid for some of those services and also funded what we call doula supervisors, which provide reflective supervision. And that's really to acknowledge that there can be a lot of churn in the doula workforce, and that part of being able to sustain a workforce that maybe will be engaging in a lot more trauma-informed care and dealing with a lot of racism in their day-to-day work, that just to sustain that reflective supervision is necessary. And the other thing is that because this work was supported through our Department of Health, this really came, the doula work was integrated with a community health worker mindset, that public health mindset. So that's incorporated in a lot of the trainings. And I know in the questions, there was also one question about midwifery partnerships, and one of our doula sites is actually a partnership between the trainee pilot site, a Medicaid provider that is a midwife, obstetrical care practice, and the local hospital where they tend to deliver. And in Medicaid, most of our doulas here are the doulas even in these pilot sites we're serving, providing labor support largely in a hospital setting. All right, so I think the main takeaway from this slide is to know that in New Jersey, we really did make a choice to build upon what our partners in the Department of Health and our nonprofits were doing in the community-based doula space, and use that to build everything else that comes after. So, excuse me, in the next slide is a timeline of what that meant. So one of the things we did was we started with a multi-stakeholder group in 2019, initially meeting in person with community-based doulas that came from our 4 pilot sites, and with Medicaid and Department of Health at the table. Over time, we began to invite other participants like our managed care organizations. And then as doulas have been enrolling our enrolled community doulas. I think the key part here, and I won't be able to cover all of the discussions that came into it, is that a lot of what you saw on the slide 2 slides ago of where our benefit landed came from the discussions in this group, as in we needed to focus on community doulas. We needed to allow doula care expansively, not just focused on labor support, but all across the perinatal period. This idea of not being prescriptive of the number or the kinds of visits, and allowing the client and the doula to engage in shared decision making. And we definitely heard that desire for doulas not to practice under direct clinical supervision. So those conversations happened both in person and virtually. And then we launched our benefit around this time last year. I think this is my 3rd takeaway, which is, or I guess we're on the 4th takeaway, is that we decided in New Jersey to launch our benefit in the middle of COVID. I think, you know, that has brought on challenges, but at the same time, we also made that choice because we knew that it was essential support during this time when maternity care really was being challenged and upended due to the impacts of COVID. And so, you know, that has been a challenge. So, and an opportunity. So in the next slide, we talk about workforce development during that immediate period around 2020 to 2021, when we were towards the end of 2020 into 2021, launching the benefit. And a lot of these supports came from our ongoing stakeholder group coming back to us and saying, we need this kind of support. And so we would try and be responsive. A lot of those things are put on our website, which I put up here, which is that we work towards increased transparency of our entire process. We also dedicated staff, both doula facing and also internally, to support the doulas through the enrollment process with Medicaid, and also internally to sort of follow how is the Medicaid benefit on, you know, how are we doing on onboarding people? What are the choke points? Reach out to our managed care partners, things like that. In parallel, our Department of Health was also doing a number of things. One key thing is, as I said, a lot of those pilot sites were on grant funding. And so there was a need for bridge funding to sort of help those sites transition from a grant model approach to a Medicaid reimbursement model. That support is ongoing. And then they also helped a lot in making sure that there were any supplemental trainings we needed for the doulas, for example, HIPAA training, to provide them for free. So if you look, New Jersey has really worked really hard to try and cut out any dollar amounts that we can, both in the trainings and also in the application process. And I just want to highlight just briefly the executive directive that was about COVID time support and allowing the doula inside the hospitals as part of that essential care team. Then, and this transitions really well to the last slide that we have, which is that most of this support continues, is ongoing. I think a lot of the work that we're doing now is just refining, streamlining, updating trainings, hearing back from doulas, what do you guys still need to successfully enroll? And now, really particularly what Linda was talking about, that support for claims reimbursement, getting paid timely. And our Department of Health colleagues continues to do parallel support. So they funded an organization called the Doula Learning Collaborative, which is a statewide organization that will provide training initially free of charge for more community-based doulas, providing training and direct support on Medicaid enrollment and billing, and also providing reflective supervision. And so I think the takeaway for the last two slides is this idea that states that are looking to stand up doula support really need to think expansively. So it's not just about how you develop the benefit, but it's really about how do you prevent churn? How do you provide logistical enrollment and billing support? We have to acknowledge that doulas are not engaging in Medicaid, not health payer systems. And so the whole process from beginning to end is brand new. And so the whole system is learning. Medicaid learned about things that we usually don't need to worry about with other providers. We've learned about that, our managed care as well. And then of course our doulas who are on the ground learning about all of it from the very beginning. And so there's really been a need for a lot of grace and patience and communication for the whole process in order to continue and an acknowledgement that that support needs to be ongoing. So with that, I can hand that back over to Preeti.
Yes, thank you so much, Shinyi. I really appreciate the highlight on workforce support before, during, and after. It's complicated to become a new provider class, and so knowing that they have that support throughout in New Jersey is really great. So we're now going to go into our questions. If you have not entered any questions in the question box, please do so. You can click on the Q&A icon in the Zoom toolbar at the bottom. I'd like to invite all of our panelists to turn on their video now. Great. And then the first question is going to be for Linda. Shinyi kind of touched on this about implementing the benefit during COVID-19. One of the participants wants to know, how has COVID-19 hospital restrictions impacted doula care? Specifically, some hospitals in their state are not allowing doulas at the bedside if there's another support person present. And some of these facilities are working on improving that. But do you think Medicaid reimbursement would be an incentive to allow doulas to be bedside? And but you can start on the impact during COVID first.
The impact was tremendous because we were basically shut out of hospitals. We were thrown into the visitor category. And so they would say, oh, no, we can only have one visitor if they were allowing one person in. They tried to not let anybody in, the people went crazy. So they said, okay, you can have one person. So then the pregnant person would have to decide whether or not it was their partner or her doula, and that should not be. We are an integral part of the birthing team, and hospitals need to understand that we're not visitors. We're paid, people contract with us and they pay us money to do the continuous care that doulas are supposed to provide. And hospitals are not doing that at all. Even California, the governor put out a thing and said, no, doulas are supposed to go in the hospital during COVID, and hospitals just ignored it. So we had to shift to doing virtual support or putting up PPE and going to people's homes and being with them, in the early and mid labor. And then when it was time to go to the hospital, we would go and cry as we waved goodbye to them at the door. It was so sad. Or we'd sit out in the parking lot in the cold, and hope that maybe they'd let us come in. There were so many stories about the abuse that was happening around that. And I don't know that Medicaid would help this. I think someone somewhere needs to let hospitals know that we are not just a person that they dragged in off the street. We are contracted with to work with them, and we are an integral, essential part of that birth team, and that we should be with them. All the work that they're bringing doulas on board for, all over the country, we're doing all these doula things. But if you're stopping us from doing what we do to ensure all these great outcomes, then what's the point? Because, we're supposed to be with them from the time they call us to come until there's a baby. That's in triage, that's at their home in triage, it's at the hospital bed and afterwards, and then postpartum. We cannot do what we do. We can't do the magic sauce that doulas do if we are cut off from our client. It just doesn't work that way, because we have to be there for the hard parts. And when you take someone to triage, it's usually when they're in very active labor. And it's the height of when we need to be there to look them in the face and tell them, you can do this. You don't need to have all the stuff right now. You're strong and you can do this. But if we're taken away from that, then they're in this little room by themselves, maybe with a partner, and they're now doing things like giving epidurals in triage, which they didn't used to do, because they're staying in triage longer for some reason. I don't know, they don't have enough beds or whatever, but they're taking us away from our clients when they need us the most. And to me, it's abusive. It's really abusive what they're doing. And some of it's new, some of it, in the Bay Area, for example, there's one hospital that has notoriously kept us out of triage. But now another large hospital system is doing the same thing. And they're saying, well, there's not enough room for you, for the doula to be in there. I'm like, I'm a rather large Black woman and I fit in this triage room for 30 years. How come all of a sudden I don't fit? It doesn't make sense to me, but it seems to be a control thing. And the other part is the massive number of inductions that are being done. Again, this is interrupting how we do our work, because they won't let us in to an induction until she's in active labor. And if we aren't with them again until that point, then all the things that we do to get them through that portion of their birth is negated, because they've already had all this stuff. They've had all the drugs that they've had, they're on their way to the C-section. It's not good. And so, as much as we want to push, Medicaid, Medi-Cal for doulas, if the hospitals don't get on board, that it's also not going to work, so that part definitely has to be addressed.
Those are the realities. Thank you, Linda, for your candidness on those difficult experiences. Shinyi, the next question is for you. For one participant writes, for states that have doula benefit, how did the state go about standardizing doula care? Is there a national body that certifies and licenses doulas? And what entity ensures doulas are providing quality care?
So I think this goes back to the point that I was making about deciding what kind of doula workforce you're targeting with your benefit. Is there is no standard. There are so many different doula care trainings, some that are more national, some of them that are more regional. We really, again, from my presentation, you can see that we really anchored to grow organically from the pilot sites that we had and the trainings that were developed there, with this idea that it would be a sort of homegrown New Jersey specific, but they are tied to national models. So they're like a New Jersey version. I think to my knowledge, there is no state that licenses. They're an unlicensed provider, and that does create some challenges in terms of in the regulatory space. As state staff are looking to stand up the benefit, there are just certain expectations that are true for licensed clinical providers that you just need to rethink and talk through for non-clinical unlicensed providers. And so what we did is we worked closely with our Department of Health to come up with a list of trainings that had been vetted and okay, and that process will continue to happen. And that's where New Jersey has landed so far. Things may change in the future, but that's where New Jersey is.
Great, thank you, Shinyi. Our next question's for Amy. A participant writes, I'm very eager to learn about the cost benefit of doulas. Has anything been published that has looked at the overall system cost saving of using doulas versus not? And anything that examines the mortality obstetric complication stats of those who have used doula and those who have not?
So I would point to, so for the first question, the cost benefit analysis, this has been challenging. I think I've seen just like a couple of things, but nothing super formal, like nothing that I haven't seen anything that's a specific cost benefit analysis that I think is like in a peer review journal. But if you look at the first resource that I shared, the California Doula Pilots Lessons Learned project, there's a summary. One of the publications is a summary of all of the 10 doula pilots that we spoke with. And many of the pilots are in the process of doing an evaluation of their findings. And so not all of them are published yet, but I think some of them, once they are published, hopefully there will be some of that information in there. To the second question, what I've seen a lot of is not specifically doula care around kind of maternal mortality stats, but more doula care in terms of some of the benefits that have accrued. So, reduced cesarean births, as I mentioned earlier, higher rates of breastfeeding initiation, lower birth weight babies. And so I think there are a number of publications, or there are a number of research and reports to support those findings, and in particular, support those findings for doula care as provided to Medicaid enrollees. I think the other thing that I would say about sort of cost benefit analysis, for sure, it's super important for, states, health plans, the state agencies to have those figures in front of them. But I will say that, one of the other things that I think is challenging about putting the doula benefits into numbers is that a lot of the support that a doula provides, you can't really quantify, right? So like, how do you quantify a birth? How do you quantify somebody being able to have avoided a non-traumatic birth experience? Even I'm not even talking about necessarily like a birth experience that ends in mortality or like severe morbidity, but just like being able to avoid a traumatic birth experience and all of the other sort of, social and emotional and mental kind of challenges that come with that. So like, I think there have been, maybe a couple of studies that look at people, individuals who did not have a doula for their first birth, and then did have a doula, and will maybe sort of try to have some kind of qualitative analysis or evaluation of what that looks like. But again, that's not something that can be quantified in terms of, I saved this much money. So, for sure, those are numbers and figures that I think are important. And I think as more states have more robust pilot programs and are sort of doing more robust evaluations, I think we will see those numbers. And for sure, those are going to be helpful for advocacy. But, as somebody who had experienced doula care and talks to a lot of doulas and people who have experienced doula care, I, would also remind people that a lot of the benefit is not going to be quantifiable. So, for sure, a lot of these evaluations are looking at both qualitative as well as quantitative data.
Great. Thank you, Amy. I think we have time for one more question very quickly, and any of you can answer this if you know the response to this, but do you have, and can you share examples of opportunities where doulas are cross-trained with community health workers as a job training opportunity?
So I can just briefly say, again, our New Jersey one was stood up in the framework of community health work, but the cross-training thing is related to some of the work we're doing ongoing, which is thinking about opportunities for other things that doulas might choose to get reimbursed for. So lactation care, we have a peers benefit for those with lived experience with substance use disorder. We're thinking about also cross-training them, and I know some nonprofits are talking about workforce pathways for not just for doulas who want to remain doulas, but doulas who might want to go into other birth work, whether that be going into maternity nursing or going into midwifery or whatever. Like, we need to think expansively about where that workforce development and pathways, where it's leading.
Great, thank you so much, Shinyi. So we are just at the top of the hour here at the end of the session. No more time for questions, unfortunately. I know this is a very important topic. Thank you for everyone for joining us today, and to our wonderful panelists for sharing your expertise on this topic. CHCS, the Center for Healthcare Strategies, we will continue to work with the California Healthcare Foundation on the implementation of the doula benefit across states. So please do look out for more information on this later in the year. As we end today, we ask that you please take a moment to fill out our evaluation form. Your feedback is extremely valuable to us. Thank you again, and thank you again to our panelists today.